So as Clara said, I'm with the National Center for Youth Law. We're an organization that has offices in a number of different states, and we use a range of different tools: litigation, policy, advocacy, collaboration, research, education, and training in a number of areas: education, health, immigration, foster care, youth justice. In my area is health, equity, and access. And I am thrilled to be with you today presenting. Our goals are that we will be summarizing the Title 10 consent and confidentiality regulations and how they intersect with state law. We will go through the state law on minor consent and confidentiality. We will explain mandatory child abuse reporting in Nevada and identify at least one risk factor or possible indicator of child abuse or neglect. And then if we have time, look at trauma-informed best practices for mandatory reporting. The material that I'll be presenting today comes from two different sources. One is a guide called Minor Consent, Confidentiality, and Child Abuse Reporting, a guide for Title 10 family planning providers. This will be shared with you all if it hasn't already. So there will be a few times where I say, see the guide for more details. And so just know that's coming. And it's also leverages information from a training and a video called Trauma-Informed Mandatory Child Abuse Reporting in a Family Planning Center, which is found through the Reproductive Health National Training Center. And because I'm a lawyer, I'm going to say two caveats: that this reflects the law in Nevada as of December 2023. This is still current as of today, but if you are going back to look at this anytime after today, you always want to double check to make sure that there haven't been any new cases or statutes or other guidance that has updated or changed the law in any way. And to that, we always say to consult your own legal counsel before relying on any statement of law. I, of course, cannot provide legal advice, just information. And especially these days, things are changing so quickly, interpretations, cases. It's really important to always consult with your own legal counsel. All right, so let's start with Title 10 in a little context. As you all know, but just to set the ground floor, Title 10 is a funding program. It was first introduced by federal Congress in 1970, so it's been around forever. It's called Title 10 because that's the section of the Public Health Services Act in which it's housed. It's the largest funding stream for family planning in the country. And the purpose when they passed this part of the act was to make sure family planning and related reproductive health care would be available to individuals. And Congress specifically called out adolescents as a priority population for Title 10 services. Now, as I said, it's a funding stream. That means that entities that accept Title 10 funding effectively enter what amounts to a contract with a commitment to provide certain services and comply with certain rules in exchange for receipt of this funding. Now, as part of these rules, programs must provide certain services. So, for example, they must commit to provide a broad range of FDA-approved family planning services, as well as some other reproductive services such as pregnancy testing and counseling, basic infertility services, and STI services. While not every site in a larger project must provide all of these services, if a program does not provide a wide array of family planning, they must have a referral system in place. And quote unquote Title 10 service sites are expected to provide most, if not all, of acceptable and effectively medically approved family planning methods and services on site, and to detail that referral process for family planning that isn't available on site. They are also supposed to provide these services in a way that is adolescent friendly and is client centered, culturally appropriate, inclusive, and trauma informed. Okay, so the system does have several regulations in place that guide delivery of these services, and there are regulations that address both consent and confidentiality. The Title X regulations state that minors must be able to consent to their own Title X care and that they must hold control over release of information generated during delivery of that care. There is no lower age limit for minor consent for Title X care because the idea is that if a minor believes they may need this, we want every door to care and to a conversation with a trained professional open for them. And of course, if they're very young, their disclosure may lead to a child abuse report, but it also may be an opportunity for education for someone who is simply confused, doesn't understand how things work. Title X agencies must encourage family participation per these regulations. Sorry, I'm not sure who's moving my slides, but if you don't mind, I can control them because I'm not quite ready. Or maybe it's out of control, but sorry about the slide back and forth, folks. So as I was saying, the Title X regulations do require agencies to encourage family participation to the extent practical. However, the regulations make very clear that grantees cannot disclose information to parents without the minor patient's documented consent. Now, in some cases, state law can conflict with these regulations. For example, there may be a state that requires parent consent for contraception. Several federal circuit courts of appeals, so the court one step below the federal Supreme Court, have been asked to look at what happens when a state law requires parental consent, but Title X requires minor consent. And the consensus across those courts was that when Title X money is being used to pay for the care, the services must be provided under the Title X rules. So that's the state of the law right now. However, as I'm sure many people know, there is a case in Texas called NVPCA that's challenging the Title X provisions as in conflict with both state law on parent consent and on parents' constitutional rights to control the upbringing of their children. In that case, a federal district court in Texas found the consent provision and the confidentiality provisions in Title X unconstitutional. The district court opinion is currently on appeal in a circuit court. And so right now, as of this date, what's happening in Texas and that ruling does not impact Nevada, but because this is changing landscape, it's really important to stay up to date on it and really stay in contact with your own legal counsel about any changes in the overarching Title X regulations due to this case and any other cases that might be coming up. But as you can see, what becomes really important is what your state law says, because this is a situation where there may be a conflict in state law and Title X. So let's move now to look at Nevada law on consent and confidentiality. Generally, a parent, guardian, or other person who's in loco parentis must consent for health care on behalf of a minor. However, in every single state, there are laws that allow minors to consent to their own health care in certain situations. They're usually divided into two categories: laws that allow minors to consent to their own care based on their status, their situation in life, and laws that allow minors to consent based on the type of service that they're seeking. So on this slide, we see the status exceptions in Nevada law and the service exceptions in Nevada law. I'm not going to go through each and every one of them, but I just want to flag that it's really important to look at the actual details of the law, which you will see in the guide that I mentioned up front, because it's important to know the scope of services. What, do they use the word treatment or prevention or services? Do they, when they say emancipated, what does it mean to be emancipated? You'll find all those details in the guide. But because those details are so important, I do want to look a little bit deeper at two particular service exceptions. So as I'm sure you all know, Nevada law was amended and updated last year, and now it expressly gives minors the right to consent to contraception. And specifically, what the law says is that minors may consent to the issuance of a prescription, the dispensing of, or the administration of a contraceptive drug or device. On the other side of the slide, you'll see sexually transmitted disease and infections. Nevada law says that minors may consent to examination and treatment for a sexually transmitted infection, and critically also may consent to services related to prevention. And the law explicitly names as an example, but not limited to, prevention of HIV, such as medications, including PrEP, prophylactic medication. Okay, so now often folks think consent and confidentiality are 100% linked. When a minor can consent, they always have a right to confidentiality, but that's not always true. And it depends on the layers of confidentiality laws that apply. So let's just talk about that, how that works first. So there are often several federal and state laws in place that may apply to protect the confidentiality of medical information. At the federal level in particular, we of course have the HIPAA privacy rule, the Health Insurance Portability and Accountability Act, that protects the privacy of health information held by covered entities, including healthcare providers who use electronic health records and insurance. In addition, Nevada has its own statutes that protect the confidentiality of information. I'm so sorry, I don't know what's happening. They keep moving the slides without me doing anything. Or maybe it's my hands, I don't know. But anyway, Nevada has its own statutes. And then in addition, there may be some other statutes like Title X regulations that apply in certain circumstances. So what does that all mean? As a general rule, what we can say is information that's protected by HIPAA and Nevada state law can only be disclosed by a healthcare provider if that provider has a signed release to share that information. That said, there are a number of exceptions in both HIPAA and in state law that allow or require a provider to release information without that written release in certain circumstances. So an example might be mandated child abuse reporting, where state law specifically requires a disclosure. That's actually an exception to the overarching confidentiality law. In the same way, HIPAA and state law allow you to share information for purposes of billing insurance without necessarily requiring a release form, or to comply with public health reporting about certain communicable diseases, for example. Now, many times there are questions about release forms, so I wanted to address that here. Under HIPAA, if a minor consented for their own health care, the minor is considered the person with HIPAA rights, and that means the minor must sign the release. And as you may recall, that's what Title X regulations say as well. So when the minor consented for their care, the minor signs a release form. Now, what about parent access? HIPAA says that a parent's right to access information related to minor consent is determined by state law or other law. And when they say other law, that can include like the Title X regulations. So if Title X requires confidentiality or minor's permission before you share with a parent, you defer to that. Nevada does actually also have law in this space. Nevada law explicitly says that a minor's consent is required to disclose any individually identifiable health information that's housed in an electronic health record so you need the minor's permission before you share with a parent if it is related to minor consent services. Okay, so that was a lot. I do not have easy access to the chat, but I wanted to just take a second to see if there's any burning questions. I'm not sure, Karen or Brandy or Clara, if you're able to share any questions you think it might be helpful to address right now. Okay, well, feel free to add something as we move on, and we'll have another opportunity for questions in a little bit. So now I will move on to child abuse, neglect, and reporting requirements under state law. What I do want to say, though, is that the Title X regulations and implementing legislation do require healthcare providers to comply with any applicable mandated abuse reporting law. But the regulations themselves, the Title X regulations, do not on their own have their own separate abuse reporting laws. So if you are receiving Title X funds, the obligation is simply to make sure that you are complying with your state mandated reporting rules. And so that's what we are going to cover today. I do want to flag that there are, of course, other mandated reporting laws, like we said, about public health. There may be some around domestic violence. This is specifically about child abuse reporting. And I do want to note that should you be working with anyone who is in tribal jurisdictions, there is different law sometimes in tribal jurisdictions. So just be aware of that. And that would be a place where it would be really important to talk to your own legal counsel about what that means for purposes of both consent, confidentiality, and abuse reporting. All right, so let's start with who must report. State law defines mandated reporters by profession. So we've just included a few here. You can see the full list in the guide. It has been updated recently to include a few more emergency medical professionals, but you'll see that it does really reference licenses. These numbers in the slide refer to physicians, physician's assistants, audiologists, dentists, dental hygienists, homeopathic physicians, osteopathic providers, psychiatrists, practical nurses, professional nurses, et cetera, et cetera. So you definitely should take a look at the full list to understand who may be a reporter. But there may be situations where in a clinic you have both clinicians who are individually considered mandated reporters. You may also have some staff who are not themselves reporters, but in those cases they might be reporting to a supervisor who's a reporter. So it's important to just understand sort of the scope of what it means when you may have some folks in a clinical setting who are mandated reporters and some who are not based on their profession. Now, there are sometimes questions, well, what if I am not on that list? I'm not a mandated reporter. Does that mean I can't report? And the answer to that, of course, is no. State law specifically says that anyone who knows or has a reasonable cause to believe a child's been abused may report, but they are not bound to follow sort of the same reporting rules as our mandated reporters. All right, so when to report. So I'd like to uplift a couple words here. First, a reporter must report when they know or have reasonable cause to suspect. So that doesn't mean you need to confirm. You're not an investigator. You don't need to document all the facts. You simply need to have a reasonable cause to believe. What is a reasonable cause to believe that abuse has occurred? That means in light of all the surrounding facts and circumstances that you, sorry, let me get it exactly right. That in light of all the surrounding facts and circumstances which are known or which reasonably should be known, a reasonable person would believe that an act has occurred or is occurring. So again, it doesn't mean that you have to confirm it. It just means that a reasonable person may have a suspicion in the same space. I also want to lift up that this mentions professional or occupational capacity. So some of you all may walk out of work, run by the grocery store. While you're in the grocery store, you see an exchange that leads you to suspect child abuse. In that situation, because it's not a professional capacity, you are not a mandated reporter, though of course you certainly always have the option to report as a voluntary reporter. What must be reported? For this purpose, there's sort of three broad categories: physical or mental injury of a non-accidental nature, sexual abuse or exploitation, and negligent treatment or maltreatment. And I'll just note for that third one, allow here means to do nothing to prevent or stop abuse or neglect when you know or have reason to believe that a child is abused or neglected. Now you'll see all of these defined in detail in the guide, but for the purposes of today's training, I just want to look at a little bit more at number 2, sexual abuse or sexual exploitation. So let's start with sexual exploitation. State law defines sexual exploitation for reporting purposes as either soliciting for or engaging in prostitution, viewing pornographic film or literature, or engaging in filming, photographing, or recording on videotape, modeling, etc., exhibition of a child's genitals, or any sexual conduct. I'd like to look a little bit more at that first one and that term prostitution. So in state law, prostitution is defined as engaging in sexual conduct with another person in return for a fee, monetary consideration, or something else of value. Now, in my office, we believe that there is no such thing as a child prostitute. When someone's under 18, this is sex trafficking, and that is in fact true under Nevada law as well. A person is guilty of sex trafficking in Nevada if the person induces, causes, recruits, harbors, transports, provides, obtains, or maintains a child to engage in prostitution or to enter any place within the state in which prostitution is practiced. In all of those cases, this would be reportable. Now, the key words here in this definition of prostitution is exchanging something for a thing of value. That may be money, cash, but it could be a roof over your head, or food, or an iPhone, or a computer. Some people may be engaging in activity that meets the definition of sex trafficking without even realizing it, because they only think of it when I say, you know, a client coming in may not realize that that's what's going on because they only think of prostitution or trafficking as something that is about cash money. So it's really important to listen for the facts of what's happening rather than focusing on the terminology that's used by the patient in front of you or the folks bringing them in. In this case, they talk about sexual conduct. That means engaging in sexual intercourse, oral genital contact, or any touching of the sexual organs or other intimate parts of a person for the purpose of arousing or gratifying the sexual desire of either person. And again, all these definitions are in the guide, so I know I'm saying a lot of words, but you can find them there. All right, so we also have to report sexual abuse, and this is defined in reference back to several criminal statutes. Each of these, like incest, lewdness, sadomasochistic abuse, are terms of art, meaning that it's sort of the words that the state has used, and then those are defined in state statutes in the criminal code. So I don't have time to go through each of these, but I just want to note that the definitions are in the guide, but I will look at 2 of them just to give you a sense of sort of what is considered reportable. So first, let's look at sexual assault. Sexual assault that for reporting purposes includes but is not limited to when a person subjects another person to sexual penetration or forces another person to make a sexual penetration on themselves or another or on a beast against the will of the victim or under conditions in which the perpetrator knows or should know the victim is incapable of resisting. It also includes when a person commits sexual penetration upon a child under the age of 14 or causes a child under the age of 14 to make a sexual penetration on themselves. Statutory sexual seduction is another important one. It means ordinary sexual intercourse, anal intercourse, or sexual penetration committed by a person 18 or older with a person who's 14 or 15 or at least 4 years younger than the perpetrator. So as you can see, there's sort of some categories of reportable activity that have to do with non-consensual sexual penetration or sexual activity. And then there is a range of reportable activity that is reportable not because it's non-consensual, but because of the ages involved, because of a disparity in age, or because of the very young age of one of the individuals. So first, in terms of sort of quote unquote non-consensual, what does that mean? Anything that's against the will of the victim, or anything that's under conditions in which a perpetrator knew or should have known the victim was incapable of understanding the nature of the act or incapable of providing consent. And anytime you have a reasonable suspicion that either of these two conditions has been occurred, that would be considered a reportable sexual event. There also are some, as we said, situations in which sexual activity is reportable based on age alone. So we've listed them here. It can be confusing, so sometimes it's helpful to create like a chart. I know that NVPCA has created some really helpful one-pagers that summarize these, but you'll see that age 14 is a really important age point. And then when you have young people who are 14 and 15, we start to look at sort of that age difference between them and a partner. When does sexual activity with a minor not require reporting? So the flip of the question that we just looked at. When there's absolutely no reasonable suspicion that the activity was non-consensual or was otherwise, incest or one of these other definitions, or trafficking. And it is either a lewd act, so that's a sexual contact that is other than penetration, and the two people involved are between ages 14 and 17, or where there is intercourse or sexual penetration or contact, and the two parties are both 16 or older, or it's sexual penetration between people who are between 15 and 18. But again, it's really helpful to look at the guide at all of the detailed ages, or look at the summary chart that NVPCA has made to really get a handle on the ages when you have minors who are seeking healthcare and sharing about sexual activity. Okay, so let's say you have information that leads you to a reasonable suspicion of abuse. How do we report? There are several stages. First is that trigger. So once you know or reasonably suspect abuse or neglect, you are required to report as soon as reasonably practical, but not later than 24 hours later. So when they say as soon as reasonably practical, when you are in a situation with a young person and they disclose information, and in the back of your head you go, oh my goodness, I think that is something I need to report, there can be this urgency and this feeling that I need to report right now. But you are allowed to prioritize meeting the urgent health needs of that young person. If you need to complete the health exam, if you need to do some laboratory, if you need to have a conversation with them, when they say reasonably practical, they recognize the busy schedule that you have. It is not a requirement that you immediately drop everything to report, but you do need to report within 24 hours. You can report by telephone or by any other means of communication that is considered reliable. If your clinic is allowed to adopt some policies and practices to help streamline reporting and standardize reporting within the clinic. So there may be a process that your clinic has adopted to help sort of make sure that folks know how to report, and it may be by telephone or by email, or it's up to you all to shape that as you wish. And then you report either to, the law says, either to child welfare or to law enforcement, and there are a lot more details in the guide about sort of where those reports go. So what must be reported when you make that report? It's quite a detailed list: name, address, age, gender, information on the child's parents if you have it, the nature and extent of the abuse or neglect, and the sort of the context of any previously known or suspected abuse, and of course, any information about the alleged abuser. Note, though, that while this is an exception to confidentiality that allows you to disclose information that otherwise might be protected in a medical record, it doesn't mean that the medical record itself is wide open. You report the information that's relevant to making the abuse or neglect report, and you're allowed to do that, even if that information is otherwise confidential. But it doesn't mean that everything, all of their medical details, should be included, or it's appropriate to do so. Now, you may not have all of the information here. That's okay. You may not even know the names of the parents or the abuser. You may not have full information on sort of what happened. You report what you have, do the best you can. But you are not required to become, again, as I said before, an investigator and ensure that you've got full information in each of these categories before you make your report. What happens with that report? Once it goes to the department, they have a limited amount of time to review it and see if it requires investigation. In some cases, they may choose not to investigate. If they do choose to investigate, they need to decide if it warrants immediate investigation, or if it's something that can be investigated but doesn't require that immediate response. And it is important to know that while you may choose to send your report to the Child Welfare Agency, there is often cross-reporting between child welfare and law enforcement. And so just because you've reported to child welfare doesn't mean that law enforcement won't ultimately see the information that you've shared. Now, often people ask, will parents be informed about the reports? You, because of confidentiality laws, may be limited in your ability to let parents know that a report's been made, but the Child Welfare Agency or law enforcement who are investigating are likely, if they choose to investigate, to communicate with parents or guardians. There is no limitation on their letting the parents know that a report's been made in the context, if they think it's appropriate. And so that's something to consider when you're talking to the patient in front of you, that, while this is something that I'm not able to share with your parents, if it is investigated, your parents may find out from the investigating agency. Will parents be informed of the reporter's name or organization? No, and that's under state law, the name of a mandated reporter is confidential. Even if the parent ultimately is brought to court and and their lawyer has certain access to files, the agency is not allowed to identify the person responsible for reporting alleged abuse or neglect. All right, so now common questions. Is a report still required if I don't have all the information necessary? As I said before, yes. If it meets that standard of a reasonable suspicion of abuse or neglect, your duty is to report with whatever information you have. Can individuals be held liable for making reports or liable for not filing a report? Anyone who makes a report based on knowledge or reasonable cause to believe a child's been abused or neglected is immune from civil or criminal liability if you've made that report in good faith, quote unquote, good faith. So there is a presumption as well that when you report, you are acting in good faith. Any person who knowingly and willfully violates mandated reporting by failing to report can be guilty of a misdemeanor. And if there is a continuing practice of failing to report when you knowingly and willfully know you should be reporting, that can have more severe criminal consequences. Can I inform parents or guardians that I'm making a report? Must I inform them. So as we said, Title 10 authorizes release of information for reporting purposes to the child welfare agency or law enforcement. State law allows disclosure of otherwise confidential information as part of making a mandated report. But that doesn't mean that information is suddenly without protection. And there's nothing in state law, Title 10 regulations that require you to inform parents when you've made a report. So if you are subject to Title 10 confidentiality regulations, the only way that you can inform a parent that you've made a report is if you actually get the minor's permission, that release that allows you to share. But it can be worth it to talk to your patient about whether that would be helpful. If you know that a child welfare agency is likely to investigate or law enforcement is likely to investigate, it is something to consider having a conversation about, or encourage them to figure out what's sort of safest for them. Okay, I'm going to pause here to see if there are any questions about reporting.
We do have a couple of questions that have come in through the chat. One is, do providers need to have a separate HIPAA form for minors?
Yeah, that's a great question. So, what the law says is that there are times when a minor needs to sign that release form in order to share records. If you provide services that also might be under parent consent. So let's say it's a comprehensive health clinic. There are some, contraceptive services provided, but also general physicals. That may be a situation where you need a form that parents sign in order to release the general physical information, let's say for a school physical. But in order to share information from the contraceptives, you need the minor signature. It is up to you and your clinic whether those are physically separate forms. What the law says is that you need separate signatures. And certainly there is an important consideration if you're trying to combine them on one form. If parents see that a child has signed and it's, check the box for disclosing contraceptives or STI information, that may be effectively disclosing information and having them on the same form. So again, it's up to you all, but as a practical matter, it's important to think about how that might ultimately disclose if they were combined in one form. But this is something really important to talk to your own legal counsel and risk management team about, sort of what's the best way to manage that to comply with the law.
Yeah, great considerations. And our second question is, how do you think the Texas ruling might affect Title 10 and healthcare accessibility in the long run?
That is a full hour
conversation
itself, right? I think we're all waiting to see what happens with the case, the Deanda case in the circuit court, and ultimately whether that goes to the Supreme Court, because the way that it works, sort of the circuit courts, their rulings, it could end up having implications nationally, but it certainly has implications for the states that are sort of within that circuit. Nevada is under the Ninth Circuit, which is different than Texas. So even if the Fifth Circuit in the Texas case, depending on their ruling and sort of what it says and what they hold what sort of the pivot point is, it may have implications here. It may just have implications for the Fifth Circuit states. But I do know that there are states that are proactively looking at passing legislation to ensure minors can access contraception. Nevada is a great example of a state that didn't have an explicit state law authorizing minors to consent to contraception up until last year. I don't know if the Title 10 case motivated that change in state law, but there are several states that also are silent in their state law around minor consent to contraception. And they are looking at doing a little bit what Nevada did last year, in part because of Deanda. There are a lot of other possible implications as people are looking at balancing sort of parents' rights and minors' rights. But again, that would be for another training to talk about that.
Absolutely. Thank you. And we do have some Title X partners who were instrumental in passing that language. So give yourselves a pat for working on that for everybody on the call. And another question, what are the reporting requirements for minors under age 14 engaged in a consensual relationship? We've reported these in the past, and CPS generally doesn't want to take the report if the partner is the same age.
So that brings up a great example. It is not uncommon for the law to require a report about consensual sexual activity between two similar age minors. And I'm talking, when I say uncommon, I mean nationally. This is a situation I hear about a lot when I do training like this with Title X funded folks in different states, because every state there are certain situations where consensual, or people can debate the word consensual, but voluntary sexual activity between minors might be reportable. It is not uncommon for the agency to say, we've got a bigger fish to fry. We're not gonna follow up on that. That doesn't change your reporting requirements. So even if you know that your agency is likely to not follow up, you still need to report if that's required by state law, because this is an individual obligation. As we said, an intentional or willful failure to report can possibly have legal consequences. Now, that could mean, though, that when you're talking to your patient, the patient in front of you, you can explain what you think happens, how your agency is likely to follow up or choose not to follow up. But we'll talk a little bit about trauma-informed reporting. It's really important that we're able to provide some information to young people about what the likely consequences of a report will be, so that they're prepared, and that can be really helpful information. If your agency has absolutely said, we will never be following up on these, I would talk to your legal counsel about is there some sort of, what can we do so that we're not forcing young people to go through this process of reporting when we know that it's never, ever going to get followed up on. The problem, I think your legal counsel just needs to work with you to think carefully about any possible ramifications if there is suddenly a policy change, or, as I said, if the report goes to child welfare and law enforcement, if suddenly a new sheriff is in town and decides that this is something that they want to take on. And I've seen that happen where in one community, somebody has decided that they want to prosecute a lot of things that meet the definition of statutory rape, even if there is no, everybody is saying this is consensual. There's no other concerns about coercion. It's not, even if it's not necessarily very young people. I've met two 17-year-olds who are both on probation for having engaged in consensual sexual activity with each other, because that technically violated their state statutory rape laws. And they were each prosecuted for having sex with each other. So that's why it's important to just work with your legal counsel in the end if you're thinking of trying to vary any way from what is in state law.
Okay, thank you. Good considerations again. And one last question for now. Do you recommend asking a minor to sign a medical release to parents if you suspect abuse?
That is a really difficult, I think that's very fact specific, right? There's a million different scenarios. Who is a perpetrator of abuse? What kind of abuse are we talking about? Is there a value in having you share information with parents as opposed to letting the system work itself out if you're making a report? Because it's so fact specific, I would really recommend bringing this to your own legal counsel and clinic administration for sort of advice. It's a kind of, if that's a question, then that's something where you probably want a team helping make a decision and making sure that you're complying with all of the different laws that might be implicated. So sorry for being a lawyer and answering that question, but it is one of those lawyer kind of questions.
Absolutely. And then one more just came in. Is a report still necessary if the sexual activity occurred when both parties were minors, technically reportable, but they're now over 18?
So that's a great question. I can't recall if we specifically answered this in the guide. I didn't put it in the slides. In in some states, state law explicitly sort of gives you a statute of limitations in effect, sort of like you only need to report if this occurred, within this age range. Or sorry, within this number of years. Some states are silent on that, and I've seen folks take um, that in sort of in different directions. And so I would say I'm not remembering if we have it in the guide, but this is something where I might recommend speaking to your legal counsel as well, about what their best judgment is on how to approach that. Sorry, I know it's no fun when I say talk to legal counsel, but at least I can say, I can tell you when there's a clear-cut black and white law on something.
Right. Okay.
Okay.
Thank you.
Okay, well, we'll move on to, as I said, trauma-informed reporting. And of course, this I'm leveraging guidance and expertise from many others, because as a lawyer, I'm not necessarily, specifically trained or an expert clinician. But what I want to say is that the guidance that in the trauma-informed reporting document that I referenced at the beginning of the guide is based on definitions of trauma-informed practice that come from SAMHSA, and that are ground in the following principles: safety, trustworthiness, transparency, collaboration, empowerment, and choice, and being aware of cultural, historical, and gender issues that can influence both sort of power dynamics and the safety and trustworthiness that folks feel. Sort of the key points that come out of this are that care and services, we want to provide care and services that are provided with awareness of a client's possible past trauma. Our goal is to try to create physically, psychologically, and emotionally safe spaces. We're really trying to help create, as much as possible, a sense of power and control over services received and even how information is used for clients. And we're really trying to avoid re-traumatizing people with processes and procedures. And all of that has a part of the core is to be as transparent and honest as much as possible. So when we apply those to reporting, sort of what the recommendations from this guide are from the clinicians that I worked with is to always set the stage before any engagement, meaning that you always explain your role and the limits of confidentiality before you engage in any kind of exchange of information. So for example, if you share something that suggests you may hurt yourself or others, or someone's hurting you, I might have to share that in order to get you help. Safety first. So as I was saying earlier, always address their needs first. There is this window. So even when you know you have to make a report, you don't have to drop your client in order to do that. You can address their needs first. Ask if this does seem like someone who may be in a vulnerable situation or may be a victim of abuse or neglect. Carefully query them about safety, and make sure that when they leave you today, that they have a safety plan or a safe space to be. When you're talking about the mandate to report, frame it as in the context of getting help, not in the context of sort of, this is something I have to do because the law says it. That really helps frame sort of the trustworthiness and the safety issues. And then when you do decide that a report is necessary, as much as possible, give them control over the process. So you can explain what's likely to happen, reinforce, the courage it took to get there, and communicate what may be shared with whom moving forward. I will actually give you an example of a case. Somebody just called me from another state, way out east. I won't name the specific state. This was someone who brought their daughter's good friend to a family planning clinic in order to access contraception because this person's own parents were having some issues and not able to focus on the needs of this young person. The sort of the friend's mom brought this young person in. They went in, they shared about some of the sexual activity that they had been engaging in. The clinic decided a report was necessary. They never informed the young person up front about limits of confidentiality. They didn't disclose that they would be reporting. And that night, child welfare showed up on the doorstep of this young person's home, told mom and dad, your daughter's having sex. She was brought to a family planning clinic by this other person, and they left it there. And so the next day, this young person who may, for all we know, is in a very vulnerable situation, came to school and said, I'm not allowed to ever talk to you or your mom again because my parents say you're a bad influence. So sort of the worst, what this mom said to me is, I was trying to be there for this young person who didn't have another adult in their lives. And I took her to a doctor when she needed it. Now she's never going to trust healthcare providers again. And now she has no more access to me as sort of that helpful adult in her life. So that a lot of what happened in that case could have gone very differently if they had informed her up front about sort of the reporting principles, if they had helped talk to her about what might happen with her parents when they're informed. Should we help talk to your parents? What is the story you want to tell, et cetera, et cetera. So that it's just an example of how trauma informed that clinic complied with the law, but did it in a way that may ultimately end up harming this young person. And it could have gone really differently. Okay, I think that is it for my slides. If there are any other questions about reporting, I'm happy to answer those or minor consent. Otherwise, I can pass it back to Karen, Clara, and Brandy.
Any questions? We have about 5 more minutes left. Okay, well, I don't see anything. So thank you, Rebecca. And thank you to everyone for attending today's training. Yeah. So this is for remember, this is for Title 10 patients, okay, this training. And you will receive a survey on this training. We would appreciate it if you could complete the survey and provide feedback. You will also receive the updated Nevada Guide for Minor Consent for Title 10 providers, the slides, and the fact sheet. So if you have any questions, please contact me at cumbe@nvpca.org. Again, on behalf of the Nevada Primary Care Association, thank you for joining us and have a great rest of your day. Thank you, everyone, and thank you, Rebecca.
Thank you all.